Hot takes, real talk, real issues. You know the deal. We keep it fresh, we keep it true. All Mary with the voice podcast.
Your first name is what?
Abuchi.
Abuchi.
Yes.
The little Abuchi, born where?
In Russia, Moscow.
Didn't see that coming. I was expecting one village in...
Yeah, we kind of got to the village, but started off in Moscow. Born in Moscow.
How? Where? What happened?
Yeah, my parents were doctors. They were studying medicine in Russia.
Both,
yeah, mom and dad. So they obviously got married, obviously there in Russia, had my older brother in Russia, and then had me and my twin brother. And 3 months later, we were in England. We moved to London. Okay. And I spent 10 years in London and then came back to Nigeria when I was 10 and a half. And then, the last year of my secondary school, my primary school.
Where are you running to?
So sorry.
Where are you running to? How was school, primary in London? You said you came at 10.
Yeah.
So how you
It was good. It was good. We were in the
normal.
Yeah, it was very normal. We were, we were in a government school. We didn't do private education. It was a good school, mostly whites, of course, but it didn't matter. They were very middle class, which meant that there was no
racial,
no racial whatsoever. My parents were doctors in the local community. They were well known, so I think everything was quite respectful.
And then at 10,
10 we had a culture shock. Came back to Nigeria for the first time ever.
Who is we?
I'm brothers. We're four boys.
Okay.
So we all came back and started to integrate into Nigeria. And it was nice.
So where in Nigeria?
Went to Enugu, which is where...
not even soft landing, Lagos.
Yeah. No. Went straight to Enugu, really. Because my father was a senior lecturer in obstetrics and gynae in UNTH.
Okay.
So we went there.
So you went straight to Enugu?
Yeah, went into Enugu, went to a school called Ekulu Primary School.
Wait, from London?
So pretty much into 4 or 5 in Ekulu, I did 1 year in Ekulu before I went to Federal.
Please tell me what's a private school in Enugu?
I don't think there were any private schools. No, Enugu didn't have there was no private school. No. So in 1979, 1980, there was no private school.
So literally from London?
Yeah.
So Enugu, government
school, pretty, but it was good. Schools were good then.
Okay.
Oh yeah, no, not like now.
Okay.
Schools were good. My first teacher was a lady called Mrs. Oboli. So she was really like a very strict woman, but she was lovely. And of course, we, as in me, my twin brother, we kind of always had a little bit of a distance because we were from England. We had an accent.
So you still have it?
A little bit.
Have the accent.
So that allowed us a separation. So we weren't really harshly kind of teased. But of course, the most important thing is that we were both quite good at school.
Hello, your parents were doctors.
Yeah, so we were pretty good. So we were always doing good grades. And that helps. It kind of helps.
Get along.
Yeah, it helps.
Did you pick up the language eventually?
Of course. Yeah.
So
I learned Igbo
very well.
Within a year, maybe 2, speaking Igbo. Fluently enough to have good conversation, understand. Writing was always a little bit of a challenge.
So wait, they taught Igbo in school, or how did you?
Yeah, they taught us Igbo in school.
Nice.
Yeah.
And then from there?
Then I finished, that was Ekulu Primary 5, then straight away you go into secondary school. So we went to Federal Enugu. So still Enugu. I did Federal Enugu, which was kind of cool. Went through that and then went to University of Nigeria in Nsukka and did my medicine there. All in the East.
Everything.
Yeah. All in the East. So that's good.
So what was your area of specialization?
So finished, obviously, became a doctor, and then did my house job in Lagos, Luth. So I came to Diaraba and did a house job for a year.
Oh, look at you.
And then I didn't do youth service. I just went straight to England and then started my program, and then decided, of course, I decided I want to be a surgeon anyway. Long ago. So I then looked to be a surgeon. It's fine. Did that. It was okay. I mean, it was tough, England, but it wasn't that bad because we were hardworking.
How were you able to, you studied here, medicine, everything went back to the UK. How was the transition in terms of
exams?
Yeah,
I had to do the PLAB. It's okay. It was a bit stressful, but
you got brains. So it was okay.
There was no
easy breezy.
Yeah, no. I mean, you could argue that some of the benefits of having parents who are doctors means that you have no reason not to do well. You can't go and say, I can't do this. It's not acceptable. You must find a way. So yeah, so it was a no-brainer. And I had a brother older than me who had already done it.
So wait,
he's a gynecologist. So he was 2 years. He's 2 years my senior. So in some respects, he had already opened up the path and gone. So I mean, there's no excuse really then.
So parents doctors, first brother doctor, you a doctor.
Twin brother's a dentist. He doesn't practice. My younger brother did something different.
Wow, this is the only one that didn't do medicine.
Well, my grandfather was a doctor actually.
Okay. At this point, you guys just...
So it's like so that was quite something.
So how did you get to the story to bariatric surgery? What triggered that interest?
Yeah, well, I think my kind of interest in bariatric weight loss surgery came a little bit later.
Okay, so what were you doing before?
I was doing a lot of upper gastro cancer surgery.
Oh.
Yeah. So I was trained as a specialist in upper GI cancers. So, much more complicated surgeries. So I used to do that as a career, and then also if you look at the history of bariatric surgery, in England or certainly in Britain, it didn't really gain a lot of massive traction till probably mid to late 2000s. So 2000 and maybe 3, 4, 5, 6, 7, maybe 8, it became very common. So when I had trained, I'd already been through my training. There wasn't a lot of bariatric training in-house because there weren't a lot of surgeons doing it. So in some respects, America and maybe other sort of continents were quicker than we were in England. So I came into bariatric surgery a little bit late. So it was like a kind of swap over, But you see, when you do upper GI cancer like I got trained, the way I got trained, and I was very lucky because I went to the Marsden, I went to St. Thomas's, I went to St. George's, I ended up in Tokyo, Japan, spent a fellowship there. So when you get trained the way I was trained, you're just good. You just have to be good because you work with some of the best surgeons in the world. So they train you and you pick up skill. And that is really important in medicine, to work with the best.
From the UK, Tokyo, you've been around a bit.
Yeah.
Did you experience any discrimination?
Oh yeah, of course. Oh yeah, of course I did. But it's not the discrimination where somebody calls you the N-word or
what
no, it's all covert. It's all hidden. So it's very subtle. I don't know, maybe discrediting you, maybe over giving you less allowance for error. So your error will be magnified as against the error of another person, colleague, like a complication or an unsatisfied patient, for example. So, but that's normal human behavior.
So you learn not necessarily.
It's not personal.
Yeah.
You don't take this stuff personal. At least I learned that because you're in a direction. I'm traveling somewhere.
You know where you're going.
Oh yeah. So some people want to block you. It's okay. You go around them. But I've always been self-determining anyway. So to be honest, it's not anybody that knows me really well. Abuchi, forget him. He will get what he wants. And that's really been something I picked up when I was a kid.
Nice.
Yeah.
Driven, self-driven.
Oh, yeah. Oh, 100%. 100%.
So bariatric.
So bariatrics, as you know, is a term used to describe surgeries that alter the upper gastro.
Like, what's the full? I think it's the longer name.
Yeah, bariatric or metabolic surgery.
Oh.
Yeah, it's sort of weight loss surgery.
Okay.
So it's a term broadly used.
So when or how did that interest
me?
Yeah,
I think it's like the trend for me.
Oh, you just hopped on the trend?
Well, in some respects, yes, because I think we know that certainly at that stage I had already become a consultant. I'd had a very broad training, which kind of means as a surgeon that I was versatile in a lot of areas. And as I said, I was trained by some of the world leading surgeons. So the attention to detail piece was something I actually was able to do quite naturally. God gave me some good hands. Mm-hmm. So I was actually skilled. Mm-hmm. So in that respect, a transition wasn't going to be too difficult. It meant doing some reading, obviously understanding some of the physiology, understanding obviously the process, the systems, the techniques, which are all quite easy. I was an upper GI cancer surgeon. I was doing esophagectomies.
We have
a complex gastrectomy. So it really was not difficult.
I get the drift. We have a nerd.
Yeah.
You love what you do.
It wasn't really that difficult. So so then I got interested. And then the other thing that was really, maybe I should kind of maybe point out is that I kind of started to transition in my understanding of medicine, understanding of skill set, but also understanding of unique positioning.
What does that mean?
In terms of, if you want to go to an area and you want to go where it's quite barren, right, to develop. So you know how they say,
be the first.
That's it. So that also played into my mind a little bit, and of course I'd already been coming to Nigeria quite a bit. So my interest in Nigeria, I knew exactly what was happening in the country and in the region. And of course I came from England and I'd seen the trajectory in England. So I had a lot of, knowledge or experience or memory that suggested that, it's always nice to be at the front. Yeah. It's better.
Be the trendsetter.
There are disadvantages, but there are definitely advantages. So hence bariatrics, yeah.
So what is bariatric surgery? What do we do? What happens?
Yeah, so in bariatrics, really, I think the team of clinicians are trying to assist patients through procedures, interventions to try and give them enough, a combination of physical, but also emotional, psychological power or ability to eat less in order to lose weight, essentially. And then use that particular advantage to start to combat things like hypertension, potentially diabetes, potentially sleep apnea or infertility or knee pains, back pains. And then the slightly more softer parts of what they do which is mood and self-opinion or self-esteem, confidence, wellness, sleep.
Some people think bariatric surgery there's a stigma attached to that surgery. People can't really say they've done it or they're going to do it because you chose the easy way out. What do you say to that stigma?
So I think there are 2 or 3 bits that come out in that type of, very correct, very factual, comment or observation. And I'll kind of break it down in three bits. The first bit, which is a positive twist for me, is if an individual makes conscious, deliberate action to improve their health and their life, they should never be nothing but proud. It requires courage. So I always respect my patients for their choices. And unfortunately, in Nigeria and all global, it's not even Nigeria specifically, globally, there's always this, I suppose it's more of an intent of superiority. We always want to feel that we have a little bit of an edge over somebody else. So we judge. It's a human trait, by the way. Mm. In reality, though, I think you find that it is definitely no easy way out. Definitely no easy way out. There's a lot of pain. There's a lot of discomfort. Yeah, and more importantly, there's obviously some financial burden involved. So it isn't an easy way out at all. And then the bigger piece is that we all have in our closets things that we are a little bit ashamed of. We just don't sometimes make them visible. And for that reason, I think it is cruel for people to judge harsh. It's cruel. I think it's sometimes as you know, you're the expert. It's a projection of their own insecurities or issues, largely. And I have seen hundreds of patients evolve through their journey and become very, very powerful people.
How do I choose the right surgeon for this surgery?
That's a really good question, really. Maybe what I could do is to maybe be a little bit more honest.
It's happening a lot locally now. You're aware.
Yeah.
And that's why I had to ask that question.
Correct.
So that whoever's watching would, yes, I can't afford Dr. Okaro, but how do they make that decision?
So I'll tell you this. I've got to be very careful because I don't want to come across over critical. Are you with me? I have to be very cautious not to appear too critical. Mm-hmm. But I do also have to draw on my experience and my knowledge of when things go wrong. As a kind of a reminder to me to bear that in mind, because we cannot or shouldn't not, be flippant or dismissive of how much skill, how much experience, and obviously, competence is required to preserve and protect life, of course. So, I always advise my patients and those that come into touch with me that
those listening right now,
those
that
listening
don't have access to you, if they want to do it, and they're in Nigeria, they can't travel. Yeah. They don't have visas to travel, but they have doctors locally promising to do these surgeries. How do they choose the right one?
I think it's difficult.
It is.
I think it's very difficult. To be honest, I think it's very difficult. I think it's difficult. I think it's difficult. I think
what to look out for in choosing the right one.
I mean, the simple things. You look your surgeon in the eye and ask them, how many cases have you done? And that's a quick start. How many cases have you done? And then following that, you can ask further questions, So you've done Sedicate. Tell me cases that haven't gone so well, and what have you done about it? How did you handle it? I'm going to go into serious mode now because, of course,
why you're here.
I have to go into serious mode.
We're talking to people's lives, so we have to.
Yeah, exactly. So the thing that I formed a society. I formed the Bariatrics and Metabolic Society of Nigeria, and I did that because I really wanted to support young surgeons and, of course, bring together the collective. Are you with me? Because I had a very deep interest to make sure that as the one who more or less pioneered bariatric surgery in Nigeria, which is what I did, as you know, over the last sort of 15 or 16 years, is to really make sure that the reputation of the practice is preserved and upheld. It's really important.
Yeah.
It's actually, those that know me well know me how important that is to me. And the simple reason is that, you look at something that is new, you look at something that seems to be promising. It's a very fragile, I think, relationship between what the public accepts or believes and what the medical healthcare offers. And that can be disrupted by careless, inconsiderate practitioners. And we don't even have to go far. We can look back at what's happening, some of the trajectories in new interventions in Nigeria over the years. Laparoscopic surgery. We pioneered laparoscopic surgery in Nigeria in 2009, 2010. We were teaching surgeons. Yeah, I was part of the pioneer group that started LASON in Luth, with Professor Chris Baudet and so on. So I have a very deep understanding of how things are, and we know how many problems we were getting at the beginning.
Okay,
so unfortunately, I think ask your surgeon how many cases they've done. Deeply inquire, obviously, as to their training. Where did you train? And I think you should really, maybe there's a duty to give you their background.
Is it okay for me to ask a surgeon to speak to some patients of his?
It should be.
Can I do that?
It should be.
So if they don't allow me to, is that a red flag?
I doubt they will. They will allow you to. Yeah, no surgeons will not stop you from talking, because it's a pride and joy. The only thing is that you want to know how many. A patient just recently on this very issue came to me, and we had a bit of a discussion. And she said to me, Dr. Okaro, I've got a really restricted budget, and that, you're much more expensive than the others, and so on. And so she asked me why. I should explain to her why.
Why you're expensive?
Yes.
Did she not see how you look? Forget the degrees, the tokens and co. Did you not look you finish from head to toe? Seeing that this guy hot. Take my money, take my short. I'm planting final.
I like that. I'm going to take my hat off for you for that. I'm flattered now, and I'm blushing actually. So
no, you are, because your face is red.
So she asked me, and I honestly thought I got to give her a right answer. I honestly, my answer was very, very straightforward. You see, the people have to remember that surgeons, especially young surgeons or surgeons who are starting a new field, have pretty usually one priority, number of cases. Yeah. And that may be just the surgeon, but it also may be the hospital. So they want to just get as many cases under the belt. So, what they do it at a cost. Get them in, build up the number quickly, make a few mistakes here and there. That's all right. We'll just kind of brush it to the side so that they can then begin to then lift up their prices in the future when their surgeons are strong and capable enough to command a better presence. So it's about learning curve. Yeah. So you say, do you want to be your surgeon? You want to be the surgeon's bottom learning curve and, just using you?
But this method literally applies to every surgeon, really, in any, not just bariatric, from what you said.
Yeah, correct. Bariatric more than any. For the simple reason is that the market is very small. As the market is expanding, they're trying to, it's a corporate plan. Why not? So that's number one. The number two thing that people forget, and you do not have any way of proving or disproving, is that you can then indiscriminately use items that are supposed to be for one use per patient again and again and again. So you don't spend as much money per case, because there's certain things that are called consumables.
Right.
See that? So you can reduce the actual cost in terms of the fixed items.
Mm-hmm.
You're asleep. How do you know? You're asleep. Nobody knows. So there's a lot of that.
So there's a trust.
There's going on. Oh yeah, that's going on. We know that's going on. It's going on. It's going on. We know that. Just
So cheap
can't prove it.
necessarily doesn't mean you're safe
I wish he was.
while you're asleep.
Yeah.
A lot is going on while people are asleep.
So that's really why you really need to brand it up to the organization, because every hospital, if it's a hospital that is in a corporate body, will have some corporate responsibility. So essentially, which kind of comes out to go to a surgeon who's working within a corporate body. Do not go to a surgeon that is standing on their own, on the private, corporate, but not in their own manager, provider. Yeah, so you get this sometimes. They own the structure, they own the building, as in rental, and then they deliver the surgery. That's 3 in 1. Who's gonna protect and reduce conflict of interest? Tell me. You think we humans aren't selfish and we have our cognitive dissonance, right? We can convince ourselves that, right?
Okay, so
you need independent others who are not clinical to tell you or watch you or vet you or hold you accountable, to never go to one person in his own institution owned by him. No, who's protecting you from him or her? So go to a corporate body, a big organization that has structures. So they will help to protect you because they have other individuals that are watching and monitoring and auditing and governance.
Protecting their interest.
Of course. So you don't hide in a corner. Right. So you be careful. That's a big, so those 2 or 3 things will generate at least enough, I think, information or feedback to give you an idea that you're dealing with a serious person.
What about the balloon surgery?
Oh, that's straightforward.
Is it still effective or not?
Temporarily.
Because I've heard how people would just be...
Yeah, you get that for the first week. But
Sorry, what?
First
week. It sounds short, but it's 24 hours in a day.
Yeah, no.
That you have to struggle with.
What you need to achieve is very
the
effective.
vomiting, let me say, so people know it's the vomiting.
Yeah, it's actually, honestly, the balloon or any of these. So the balloon.
So who would you? We'll get to the questions of who is the right candidate for bariatric or balloon. I'll get to that after this question. Then we'll get into our stomach size. I am tired of overeating. Personally, I call myself foodie, but I think I'm not going to say that again because they say words, your words manifest. So I'm not a foodie anymore, but I like food, but I'm not a foodie anymore. How is it that some people have more control over what they eat? They finish a little plate and they say, okay, no, I'm okay. I'm done. And then the likes of me and my fellow cousins and uncles will see that big, mighty plate, will finish it, still drink a whole whatever next to it. And then 2 hours later, we can still, nibble something again. What is the size? What's the size of the stomach really? And can I train it to reduce and maintain the size?
I think the simple answer is kind of yes. A straightforward answer is you can train your stomach to be a little bit more satisfied with what's given.
With this, what size?
In terms of size, yeah, exactly. But it is hard, and the reason why it's hard is that hunger is an emotion. If you remember,
is it?
Hunger is an emotion. Hunger is a feeling. It's an emotion. You feel hungry, so it's going up in the brain, right?
Mm-hmm.
Yeah. But there's also the physical component where you feel empty, right?
Right.
Yeah, and the two have a bit of a conversation. So the stomach and the brain are in conversation fairly regularly. Are you with me?
Mm.
Now, again, you're a psychologist, and you know that the input of information in and out of the brain is kind of linked to so many things around our deeper emotions, our deeper feelings of, let's say, happiness or unhappiness or anxiety or low mood. So all of these are so complex emotions that make us make what? Choices, right? They create thoughts, which makes action. So it's very complicated, I think, essentially. But I think if you have an ambition or you have an intent or you have a good reason to make change, which means to try to bring your weight down or maintain weight, and you have a really strong emotional reason for it, either medical scare or, a physical pain or something, or a chronic condition like diabetes or whatever, then sometimes you can find the will, the power for that. But it is desperately difficult
to reverse it, to reverse the size.
Yeah. So that's why surgery is really helpful. So
once it's ballooned, you can't.
Once your stomach grows, it can shrink a wee bit, and it can for sure, but not. It takes months
for it to shrink.
Yeah, for it to sort of contract, because it's like an elastic. There's a degree of elasticity in the stomach, so the stomach will kind of shrink a little bit, But unfortunately, I think we're all guilty to a large extent of eating more than we should, or indulging in more than we should. And that's, I think, just especially in our own area, because of course we were taught to finish what was on our plate.
Right.
That's a traditional Nigerian thing. Finish what's on your plate. So you never really walk away with something on your plate. And we were doing that as children, because our parents told us, finish what's on your plate.
But our culture also is, if you're skinny, you're not healthy, you're not well taken care of. You have to look.
Yeah, but I think that's changing now. I think that thought is moving. We're moving away because of the science that tells us that we are eating ourselves into disease or dysfunction.
So I almost feel defeated. I don't know. Hold on. Let me rephrase that question. Maybe I won't feel defeated. So you're basically saying that once the pouch is overstretched, even if I reduce my portions, and that would explain why a lot of people struggle to lose and it comes back. So even if I reduce my portions for a month or two, trying to eat healthy, I will still feel like I'm not full. I have to fill it up. Or
you might do, but then again, you may be able to block and ignore the signals. Don't forget it's
block.
Block, as in ignore.
So it means I'm not really hungry, but my brain is telling me to eat.
Yeah, correct.
So that's struggle. So that's a struggle.
So that's a struggle, which is why some of the chemicals people use are Zempic.
Right.
And
the semaglutides.
Yeah. They create a signaling that reduces hunger, which means that people, and also it keeps the stomach delayed in emptying a little bit. So all of that ends to contribute to people losing weight. Simply that. It's all up here. It's all in the mind, in the emotion and feeling of hunger. I know maybe you could add a bit of nausea, maybe a bit of feeling discomfort, fullness. They create negative loops up in the brain to say, stay away.
Okay, so there's nothing like you're starving yourself. I could literally starve myself skinny. Or must I put something, because we're told there are digestive enzymes in your stomach. If you don't eat, ulcer issues could happen.
Yeah.
So I'm hungry. How much can I put in there without, one, causing ulcer over time, and two, to say, yes, I've lost the weight. Let me see if the pouch would go down with time. And once I've lost the weight, tell my brain, okay, this food is enough for you. Even if I get the signal, okay, it's time to eat, I can drink water and I should be fine.
Yeah. You're absolutely right. You can do that. It's a retraining. Because of course,
so we can retrain our brain.
Yes, you can. Yeah, you can. You can completely retrain your brain in a direction that is of your suiting or your favor or your preference. So let me sort of kind of bring up this thing they call hypnoband. Have you heard of a hypnoband?
No.
Yeah. So there's some hypnotherapists in certain parts of the world
Mhm.
that use hypnotherapy to hypnotize people into thinking they have a gastric band.
See, they shouldn't try it in Africa. No, not Africa, not Nigeria.
So,
No.
and for the people who are hypnotizable, it's very effective.
Hold on. Have you brought that to Nigeria yet?
No, God, no. I'm not a hypnotherapist.
See,
So
let,
I know.
let them train me. Let me be the one to try it here and
So
see
you should
how they
research
look at
it.
me say, Madam, I beg, get out.
And also, more importantly, they'll charge you. There's not going to be for free, so there's going to be a little bit of a transaction involved to kind of get that. And they're like, so you get to my head, make I don't get banned. So you're right that that's not going to be something that viable because of the way. But the point really to that was to highlight that a lot of it is here. Are you with me? So that's one thing I think I want to just kind of mention. The other thing that I should say is this. If you have nothing in your stomach for a period of time, we call it time-restricted eating now. It's very topical, right?
IF.
Intermittent fasting, time-restricted eating, 1 meal a day, there's a lot of it. You will not get ulcers. You will absolutely not get ulcers. No.
Okay.
So, I think that we have to understand that giving your gastrointestinal system, the gut, time to rest and relax is very helpful. So time-restricted eating is a very powerful tool, because I think, you kind of go with the old saying, all the neurons that wire together, fire together. So very much is the emotionality, the feeling around habits of eating or feeling, because you read the book, The Body Holds a Score, right?
Oh, yeah.
You read the
He
book.
remembers every single thing.
So, and that's really important because what it's doing is we're having what we would call triggers, right? You get a feeling in your part of you and you think, oh, food. And your brain goes,
Isn't that a hunger signal, though, that gives it to my brain?
is it?
Isn't it?
Is it? So that is always a point we say to patients. We associate certain feelings in the body with certain action points: eating, drinking, moving. Yeah. So yeah.
How do I know I'm a candidate for either the balloon or bariatric? And the bariatric now has the sleeve
Or the
and
bypass.
it has the bypass.
Yeah, they're the
we have
two,
the
yeah.
sleeve, we have the bypass, we have the balloon. Now I'm coming to you. How do I know I'm a candidate for?
So I think it's obviously really important to define that because it's clear that the definition or the guidelines are there. Anybody that has a body mass index of about 28 and above is suitable for either balloon, sleeve, bypass, depending.
So body mass index, they can check it
But-
online,
but-
what it means,
yeah.
check your weight, check your height.
Exactly, and then do the calculation. So anything above 28,
You're
you're
isn't there
candidate.
body mass index for Africans? Don't we have
And
our
sadly,
own?
there isn't.
Can we have our own? Because
No.
you are you're the nerd.
No.
Can we not research and come up with our own?
No. That's not going to happen. I think the body mass index is a nomenclature or term
No, it
that is
doesn't-
not
but
subject to any change.
But you and I know it doesn't take into factor your
Muscle. Yeah, I completely agree. But people have complained about it forever.
We're not complaining. It's science.
Yeah, I agree.
It's not a complaint. It's science.
I agree.
You cannot look at someone that is packed
I agree.
and then he's
agree.
110 and you look at him, tell him you're overweight.
Yeah, no, I agree. So what would, I mean, you make a really important point, but the whole community have been complaining about this issue globally, but we've accepted that it's probably not that required of us to spend too much time and energy on that issue of bringing something to substitute the BMI. And the simple reason why is there's a machine called a DEXA scan. Okay. So a DEXA scan, which you go into, will give you a comprehensive schematic of your body. And it will tell you in proportion how much of your body is muscle, how much is fat, how much is obviously organ tissues. Now, You then look at the DEXA scan and then decide. So if you have a DEXA scan showing that you're, as a man, have a body fat content of 30% and above or whatever, pretty clear, right? Yeah. So the DEXA scan is where there's any doubt.
So there are machines now that can help with the BMI to make sure that we're not.
Yeah, it's more just to see how much body, because what you're looking for is the total body, how much of your weight is made up of fat.
Yeah.
And there's certain acceptable values.
But culturally too, we have the pressure of looking a certain way.
Which way is that? Which way is that, may I ask?
We need to.
Are you talking about men or women? Because, it's different. For men,
thank God,
women.
The pressure on women to look thick. We can't look skinny because there's nothing to hold on to. And if there's nothing to hold on to, you have the pressure of what? So she's trying to be healthy in a, let's say weighing 70 something. And then you have the men like, oh no, there's nothing on her.
Yeah.
And she has to weigh 90 something to be curvaceous.
So I agree that there's a bit of that going on. I think there's less of that now, at least not less, spoken about openly. I think in sort of polite society. Definitely, I agree with the physicality, the physique,
the struggles that we have as women.
Attraction piece.
The BMI has to be. What'd you say again? If I'm
28 and above.
Of 20, I think I'm above 28.
Yeah, but then again, don't forget.
Then the problem now is if I psych myself, do the starvation, do IF, all of that, and I come down to 25, all of a sudden I'm not attractive anymore.
Yeah, and I agree. That's a hard one. I agree. I think the balance, definitely the balance with the BMI in question, I think is not to be treated so literally. So I'll give you an example. So and that is the question you're kind of, the point you're making around Caucasians and obviously Africans or Nigerians. So somebody with a BMI of 28 in Nigeria and a BMI of 25 in the UK, they may well sit quite similar in terms of proportion. So a BMI of 25 in Nigeria and a BMI of 25 in England are very different in terms of structure because of the way we distribute, obviously, our body kind of contours and so on. So I agree with you 100%. Yeah, don't forget, honestly speaking, we're not looking to make people skinny. We're not really, we just want to make people healthy.
Okay.
We want to make people healthy. We want to reduce the chance of getting chronic conditions like diabetes or hypertension, or issues around your hips or knees, joints, pain, from just, carrying around a little bit more than you should. And then, of course, the ultimate aim, which is to reduce the risk of inflammatory conditions that can lead to cancers. And then self-esteem, confidence.
The risks around the different surgeries. I think we just do the bypass, the sleeve, and the balloon. If there's is there any other one you want to add to 3?
No, I think those.
What are the risks?
3. So
with these.
The balloon is day surgery, endoscopy.
Day surgery.
Yeah. The balloon is in and out through the mouth. So you put the camera in gastric balloon.
Right.
You put the camera into the mouth, and then put a balloon in the stomach from the outside.
It's not a balloon you put in. So what do you put in?
So you put the tube. You put the balloon, but it's collapsed, obviously,
right.
And then you blow it up.
I'm asleep.
You're sedated. You're awake, but you're sedated, which means you're kind
no
of
refluxes.
No, you'd be sleepy. You'd be sleepy. Yeah.
Won't I gag?
Most people don't. No, you could, but normally no. We give you some anesthetic spray for the mouth. Okay. It's just like having an endoscopy.
Oh,
those that have endoscopies. Yeah, essentially the same. The only difference is that you're going to have a balloon go down at that time.
Go ahead, explain that.
So you put the camera down, position the balloon in the stomach, collapsed, emptied, and then you blow it up with usually water with some blue dye.
So I have something heavy in my
Yes. Good way of describing it. So you go up to about 500 mils, 600 mils, which is about 600 grams.
That's about this much.
Yeah. And it sits in the stomach for up to a year, maybe.
No way.
Yeah, it helps people.
So literally, I have this size of
a bowl. In your stomach. In your stomach.
A liquid.
Yeah.
Sitting in my stomach.
Yes.
So when I eat, how does it bypass the ball
when you
in
eat the
terms of
food?
digestion?
Yeah. So what happens is that it sits slightly high in the stomach at the beginning, higher.
Mhm.
The stomach is quite long. The stomach's about this long from top to bottom. So it sits in the stomach at the beginning high. So food has to go around it, which is why you can only have sort of mushy, liquidy stuff for a week or two. So it doesn't go and form a big blockage. And then eventually it drops a little bit in the stomach over time, and then you can create some space. So you really have a small cavity, which is why you feel full a lot quicker.
So there will be one part of the stomach
below that is relatively empty, and there's a bit that above that is small but gets full quickly because the balloon sits and sort of creates a bit of a restriction.
Mess the digestion, and
it can mess the digestion up in some instances because it can allow things hang in the stomach longer. Let's say instead of staying in your stomach for 4 hours or 6, it stays for 24 hours. So you can get certain foods may ferment, right?
Ooh.
You get gas production. So that can happen. Yeah.
What about the risks with that one?
The balloon risks are more just the inconvenience of having it done, and of course the reflux sometimes. But that's it. It's very straightforward, very low risk.
So I remove the balloon. My stomach size remains the same. We've had that
for a short while. It will contract a little bit over the coming month or two.
How do you take it out?
So the balloon goes in. We put it in, blow it up.
Mm-hmm.
Okay, and leave it in. And then when your time to remove it comes, you come back. We go back in with the camera. Use a special needle, puncture it, suck out the fluid in it out of the body, suck it into the receiver, and the balloon is now collapsed.
So you collapse it in there before.
Inside, and then you grab it and pull it out. Just pull it out. It takes 20 minutes. 20 minutes. Straightforward.
To take it out?
Yeah, 20 minutes
to put it in?
20 minutes. 20 minutes. It's not long.
Oh, wow. And it can stay for a year?
Cannot stay.
So who would be the
best candidate? The perfect candidate for balloon would be somebody who, for example, just needs to lose about 20 kilograms. Not more.
Okay.
Not more.
Okay. If I want to lose more,
then one would really want to think of doing something a bit more drastic, something with a bit more.
Which one would that be now? The bypass or the sleeve?
Yeah, either. Actually,
which one would you advise first?
So the commoner and more popular is a sleeve, and the reason why it's a sleeve is that the sleeve in our environment.
Mm-hmm.
Because of the kind of food we eat, which is big, we eat bulk, rice, yam, swallow, whatever. They are, they're quite
bulky.
Yeah. So when you make the stomach so much smaller, you'll get a good impact. So the sleeve is most popular globally anyways. It's not as if in Nigeria is any specific case. Sleeve is popular globally. And that's why it is. And the same applies to Nigeria. However, I think that if a person has a slightly more high sugar content diet, so if they like to have a lot of Coca-Cola or a lot of Western crisps and biscuits and chocolates, then I tend to think maybe the bypass might be a bit of a better because bypass stops you from absorbing some of the food you eat. So you get some food.
Also, there's this difference. Candidate difference now.
Yeah, so it's a restriction and then malabsorption. So it stops you from absorbing some of your food, which is the bypass.
Right. So you would literally need to know the lifestyle of the patient.
We go into detail. Yeah.
Which one
is preferable? Yeah.
So that means I would lose more weight with the bypass?
There is, there is a little tendency to lose about 10% or 15% more with the bypass. Yeah. Yeah. Because of that restriction, plus on malabsorption, inability to absorb some of the food. Correct. Yeah. So that's a good point. Yes.
So if I do the sleeve and I struggle to lose more weight,
you could get a bypass. Yeah. We could make your sleeve into a bypass. Yeah.
Possible.
Yeah. Oh yeah. Very, very quite common. Yeah.
Doesn't have any complications.
Well, the complications of all of those sleeve or bypasses, things like bleeding, infection, leakages, and so on. So those are some of the risks.
Casually, sorry, your doctor just casually bleeding.
But yeah,
can we not just casual bleeding, infections.
But yeah, no, I mean,
Okay.
the two serious risks are bleeding,
How? What does that mean?
as in internal bleeding.
Okay.
So where you lose blood into the stomach or into the abdominal area. So the surgery's over. Of course, you're in the recovery or you're on the
How long is the
ward.
surgery?
It depends. I mean, for surgeons who are very experienced, it can be an hour. Those that aren't, 3 hours, 4, who knows?
Oh, but
Yeah.
it can be done in an hour.
Oh, yeah. Most times it's about an hour.
How long will I stay in the hospital?
1 night.
For observation.
Hmm.
So the risk basically just the bleeding.
Hmm.
People think sometimes that it's so easy. I come and see you or see, whoever from, I've done my consultation. Okay, let's do the surgery. I have my money. Is there a pre-op follow-up? What is the pre-op preparation for such surgeries, even with the balloon?
Yeah, so the balloons, so that's a really good question because, of course, you don't just let you walk off into surgery. No. The body needs to be given a check, right? The body needs a check and like a health check. But the body also needs to have the environment made sustainable or favorable for the procedure in hand, balloon or bypass or sleeve.
What does that mean? Suitable.
So suitable, which in the case for the balloon will be to make sure that we reduce the acidity in the stomach with omeprazole, for example, reduce some of the spasm tendencies and nausea with certain drugs 2 or 3 days before.
Oh, before the surgery.
Before you actually put the balloon, before the procedure. This is for the balloon.
Okay.
For the bypass or the sleeve, same preparation, I must say. The liver, which is the organ we know, everybody knows. We all have a liver. We can't live without a liver. We all have a liver, yeah.
Right.
So we can't live without a liver. So the liver is a sort of a triangular shaped organ that sits up here on the right and crosses to the left. And the liver sits on top of the stomach. So if you're lying on your back, your stomach is, a good portion of your stomach is under your liver.
Right.
When you're lying on your back.
Right.
Yeah.
Mm-hmm.
So if you have a big liver, which a lot of people who are slightly overweight do, then the liver gets heavy and it has to be lifted for a surgeon to get to your stomach to do the surgery. They have to lift the liver up.
Right, the line down.
Yeah. So you need to use a machine to lift the liver or a little retractor.
To get under.
So if the liver is very big and heavy, what's it going to do? It's going to get in the way of the surgeon. So you need to shrink the liver. So it's called a liver shrinkage diet.
You can do that without the person losing weight?
No, they'll lose a bit of weight. Yeah, they'll lose a bit, maybe 4 kilograms.
So the person has come to you to lose weight.
And you have to shrink the liver to make them, yeah. So yes, you're right. I mean, it does sound a bit.
How do you get someone that is struggling to lose weight to come to you to lose the weight, to go lose the weight before they come to you?
There we go.
Did you get that?
There we go. What do they say? Where there's a means, there's a way. Where there's a reason. Yeah.
How do you get them to do something they couldn't do to come to you to
Well,
want
they're
to
not
lose
doing
weight?
it permanently. They're doing it for a short period of
So
time.
they can't adhere to that. They do?
Well, they have to. So they don't get the surgery.
Oh.
Yeah. If they don't get the surgery. Are you with me? So you and I know that, when you tell a patient, or not a patient, when you tell any individual,
Mm-hmm.
you either do this or this is not going to happen, and they want it. What do? Yeah, if we want it bad enough, we're going to do it, right? Happens in relationships when you're put on the spot.
Either
make that change or I'm out of here.
Yeah.
So it's just a human reaction to pressure or a
you have to at the gunpoint.
Yeah. So they do. It's only for 2 weeks.
Okay.
Not big.
So what do they have to do in the 2 weeks?
They need to go on a diet that is very low in calorie, usually about 1,200 calories.
Do you give them what
we
to
give
do?
instructions, clear instructions? Yeah, literally they get the book. Use this, do that, and it's usually protein based. Yeah,
like what? So it's
protein shakes.
Also, they have to go on shakes.
It's usually protein shakes and yogurts, and so on.
Soft stuff.
Yeah. Usually that.
Do you have to prep them mentally with changing diets before? Because post-surgery, how would you know they're able to adhere to the post-surgery diet if they struggle with the pre-surgery diet?
Well, that's why if they don't do the pre, they don't get the post.
No, but they do the
surgery.
pre because they know what they're going to get.
So yeah, no, I agree. This is really, I think, you're the psychologist, so you really are the one to answer that question, because I think you know the answer to that question. Are you with me?
I'm asking that not as a psych, but for people wanting the surgery to be aware that it's not just, okay, I can starve myself for 2 weeks and get it done. And when I'm post-surgery, well, I've gotten what I wanted anyways. So now I must be honest. You know how it works when people try to go on solids.
They want to game the system
earlier than.
Yeah. So I think you're right. And I must be very perfectly honest. I'm just trying to, remember and look in my own sort of crop of patients to see if I've ever had anybody that has struggled. I think I can only recall of maybe one individual in hundreds that has had or hasn't admitted to it. They never admitted to it, but I could, sense there was a bit of a struggle. The psychology piece, and I was obviously.
Do you do the psychology with them here before they get the surgeries?
Yeah.
Abroad, they have. Here it's elective. You have your money, you do it.
Yeah.
There, you have insurances.
Correct. Yeah. So, psychology is really important. And I think you really do make a very, very important point to order to understand, I suppose I don't know whether you call it the temperament or the degree of responsibility or ownership that these individuals have. And I think experiences are very valuable. Experiences are very valuable, kind of a teacher really, because I think we do get a very, very, very keen sense of a person's psychological makeup after 1 or 2 visits.
Okay.
Yeah, I mean, we're very, very canning. And of course, the other thing, as I'm sure Sharice has been to you. Sharice has had a chance to talk with you as our
session together
nutritionist and our more or less our kind of. She's such a great anchor to the service that she and I offer, because her holistic mind, body, spirit approach really gives her and helps me to get access into the back office of the mind, which is key. I'm getting better at it now.
You're doing a bit of psych work now?
Oh, yeah, huge amount of psych work on myself mostly, but yeah. So I understand, and I think we all, you're an expert at this, so of course I'm not going to second guess you, and I'm certainly not going to put words into your mouth. But my job in my clinic is to get people to take their masks off and show me their true selves. And I'm getting really good at it now. I am. I know I am. I'm getting better at it, much better at it as I get older, because age brings a level of unapologetic authenticity. Is that the right word to use? Yeah, which means that I will be genuine in what I want to do for you, but I want to help. And if I want to help, I got to know the things that are going to get in the way of achieving our goals.
How much time do we expect, or do you expect people to lose that desired 20 kilos? Because I've done this surgery.
This is for the balloon then?
I've paid.
Is it a balloon?
For the 3 of them. So I've paid a lot of money. I've gotten the surgery. I starved myself. And now I've lost. Some people even say they gain weight post-surgery before it goes off. Can you shed a bit of light on the post-surgery expectation in terms of weight loss?
So I think if we break up the journey of the patient into those categories, the pre-op, the intra-op, and the post-op, and then break the post-op into the short-term post-op and the long-term post-op, then I think we can have conversations that maybe reflect what's needed. So the pre-op obviously is straightforward. You need to come, get to understand the patient in a bit of depth. Always encourage patients to come with company. Okay, so they should have somebody either their partner, if they have a partner, or their children, or their parents, depending on their age and whatever, because it's always nice to have somebody who is with them to support them. We find that really helpful. But also, these are sometimes long conversations, 30 minutes, 40 minutes. You can't remember everything. So somebody also helps to keep that store of information. So that's really helpful. It's for the pre-op. The intra-op, obviously, is straightforward. Do the surgery, they recover, then go home. The post-op in the first phase, short term, is really important that they don't do anything to their new stomachs. Now, this is the bypass.
How long is the short term? How many weeks?
3 to 4 weeks.
Okay.
They'll be on liquids so the stomach doesn't stretch. So
what do you mean by liquids?
Liquids, start with just simple liquids. So it could be broth, of course, yogurt, which melts in the mouth and becomes liquid. All the teas, smoothies.
So that's the food you're talking about?
Yes.
3 weeks.
Yeah, so it'll be liquidized. Yeah, it'll be liquidized for about 3 weeks.
Tea is not food. You just mentioned tea. That's
well,
not food.
Hydration is
no, forget we know hydration. I'm trying to help people know.
So the food piece will then be usually protein shakes. Protein shakes are quantifiable in content, not just calories, but also micronutrients and so on. So protein shakes.
For 3 weeks post-op. That's all you're gonna have.
Majority. No, you'll have other things. Broth. You'll have some bone broth.
Broth sounds so posh. Yeah, it's water.
It is water. But it's got a lot of fats and good chemicals.
Is it magnified water?
It probably is magnified water. But the idea behind it is that it is very critical, though, at that initial stage, that we don't get any blockages in the stomach, because that's going to prevent. It has to. That is what's going to prevent the stomach from potentially getting blocked, which then means that it could get under high pressure and leak. And if it leaks, the patient needs to go back to surgery. So this is very critical. It's very critical. So it's not great for the patients. It definitely isn't the most enjoyable part. But I promise you, I've never had, as far as I can tell, anybody bitterly complain. They are taking ownership of their own wellness. And it's so important that, of course, we need to make sure that they're going to be committed, of course. So, yes, that's quite important. So, yes. So that's
3 weeks.
3 weeks, yeah.
After that?
Then you build and transition off to something smoothies, and then all the way scrambled eggs, custard.
Sorry, we're in Nigeria. Give me Nigerian foods.
Sharice would give you all that.
No. So you don't. Yeah. Okay. So
I don't get too. Yeah, I don't get too deep into
the stuff.
Yeah.
So when can they go back to solids? So let's do.
Normally, I expect them to start to dabble them in solids at about 6 weeks.
That's when they can do
solids. Yeah.
Back to what they used to have before.
Yeah.
Do they have to change their diet?
Oh yeah. Absolutely.
Or can they do what they were doing before?
Would
I have food aversions? Would there be issues with certain foods I can or won't be able to tolerate because my stomach is different?
So yes, everybody goes through their own individualized journey. So yes, I think that we allow for the reintroduction of what would be considered their normal food over a period of about 6 months. Yeah, you may not tolerate, let's say, for example, maybe a piece of mincemeat on month 3, and on month 6 it goes down perfectly fine, because the stomach is still going through quite a bit of change.
So you have to learn to re-eat.
Yeah, you got to be patient. You got to learn how to eat again. I think that's a very good term to say. You're literally beginning to develop a brand new relationship with food. The other thing that is really important, I think, is, at least I try and I remind my patients that what you're literally doing, having had a sleeve or a bypass, not a balloon, I think we can leave the balloon because it's such a temporary, low impact device so that you can put this to the side. So I'm talking about the bypass of the sleeve. Is really to remind patients that actually you're fueling your body for a purpose, which should be energy, and obviously digestion, and then going to toilet and so on. So you focus what food does. What is the purpose of food? Is life. We know that, yeah? Food is energy, food is life. But you got to eat to reflect that.
Right.
Are you with me? And if you're going to eat to reflect that food is life and food is energy, then you need to eat healthy, good things. Right?
Right.
Yeah. Because of the literature and the research and all the evidence that's coming out now, it is very clear, processed, natural. You want to eat processed?
Choose. It's your choice.
You see what I mean? So that is critical. Are you with me? So part of our job is not just to make your stomach smaller or bypass you and let you disappear into the wilderness.
Yes, I was going to ask that question.
No, you got to come back.
Yes.
The follow-up.
So I was going to ask that question. So I leave after the first night. I go home. I'm recovering. I'm doing my shakes for 3 weeks. When should I be worried there's a problem? Or what signs should I look out for
if something was going wrong? Yeah, I mean, I think the really serious problems like bleeding or leak or infection, they declare themselves very quickly. You don't think, am I leaking?
Or like what would
pain, serious pain, serious pain,
stomach pain,
serious pain, morphine, screaming. Yeah, it's like you wouldn't be sitting at home with a leak, snoozing and thinking, no, you'll be on the phone, you'll be in an ambulance or in a car going to the hospital. So that's leak pain. It's intense. It's excruciating. You need morphine or fentanyl or pethidine or pentazocine. It's that bad. It's agony. Yeah. So somebody rings me up, Doc, I've got a bit of ache here. I think I'm leaking. You on the phone talking to me. You are not leaking. So it's very clear because it's peritonitis. Yeah, very toxic. So that's for if you leaked, you will know you'll be in hospital. If you were bleeding slowly, then the way that may present is you might stand up and get dizzy. You might start to feel your heart palpitate. You might start to feel just woozy and low energy. You're going to be pale. I'm so pale. I'm looking white so that's bleeding. That can be a little bit, because the bleeding in this type of surgery is not necessarily always rapid. Just slow. Takes 2 days, 3 days, 4 days. So those are the two ones. Now, other things like your wound might start to get a bit oozy. You might have a cough. Maybe if you've got a chest infection. Or so. I mean, the good news is that very few people get into trouble. 2%. That's probably the good news.
I feel so defeated once again. Long-term deficiency in nutrients. Since my stomach is not absorbing a lot anymore, some with the bypass more, with the sleeve less so, will I have to be on long-term supplements for vitamins?
Yeah, I think most good centers recommend lifelong supplements of vitamins after bypass.
Lifelong.
So
people need to remember there will be cost involved in, or no, can I choose when not to, or I have to?
Yeah, you ought to. You ought to take the vitamins regularly. You ought to.
So there has to be a financial plan.
Okay, layout.
Yeah.
I don't think they're that expensive, actually.
Sorry, have you seen the cost lately in Nigeria for basic things?
I know. It is tough. It is high. But I think the vitamin piece, I don't suspect should be I hope not. I hope not. Maybe.
Oh, Lord. So what if I end up having some food issues with food, or will there be a case where I won't be able to tolerate certain foods at all, even after 1 year?
Yes, there may be.
What's
there are some
your experience with that?
I have some patients who can't
They love
tolerate
certain
certain
foods
things.
before, and now it's like,
Yeah. So I think the piece that we haven't really highlighted in our conversation so far is that there's something that goes on with the taste. The taste and the brain, something goes on with taste in not all, in some patients. So you have patients who like, let's say, Coke, or they like chocolate, or they like something sweet. They finish the surgery and they don't like it any longer.
oh,
Yeah, they don't want it. They just don't. It just doesn't fancy. They don't fancy
is
it
it
any longer.
something with the stomach?
It's the stomach and the brain. It's the taste. It's odd. It's
Is there disconnection in the stomach? Or
no, just taste and cravings just change. It's something sensory. I don't know. It's well described, by the way. I can't really tell you what the real mechanism of it is. So you get that sometimes, and I think that's powerful, because some people they live on sweet things or Cokes and stuff, and they can manage to get off it and not go back on it, and they find it really empowering. I don't need that Coke any longer, or I don't need that chocolate bar. God, I'm so good.
it's just
But on the food side, yes, you get some people that can't tolerate certain food,
Certain
pasta,
food.
yes, or rice or whatever. So it happens. Yeah. I have some
so
patients
it's
who
not
can't.
necessarily even the taste.
No, this
The
one is now
stomach-
the stomach. The
Yeah.
stomach, for some reason, it rejects. Yeah, that's not as common, but it can happen.
And that is also patient to patient, not general thing.
No, definitely, yeah, patient to patient, yeah. It's hard to tell. I don't know. I had a few patients. I don't know. You check, everything looks okay, but the good part and the bit that I love is that they rarely come back complaining about it. They're just giving you information.
Oh, okay. This one is something I've seen a lot online. There is a group I'm in for weight loss because I have a few friends that have done the surgery. So there's a group on Facebook that I'm in to learn, not to do it, but to learn, because you end up seeing the good, the bad, the ugly, and how people are coping and some tricks they're using to also maintain. So I use those tricks for myself without, having done it. But then we see those that have regained their weight.
So
people sometimes think the surgery is the lifetime. I fixed it. How does it happen? They end up back to square one.
Yeah, no, it's complex.
I'm here.
It's complex. It's complex. I'll flip the question round. Maybe. Why are there some people that can have bariatric surgery and 10 years, 15 years later, they're doing super well? Why? Yeah? Why? So I'm flipping it around. You see what I mean?
Mm-hmm.
Rather than focusing on that and the ones that don't do so well. And this has been studied extensively, in scientific, through scientific projects and, of course, different research projects, global, because everybody wants to understand, and I think could maybe deduce that from my experience and also from what I read and what I've heard from, centers that have done, hundreds of thousands of these cases, and I've followed these people up for 25, 30 years. But there are a few things that are very, very basic and very important. Are you with me? And I will probably just maybe highlight some of them. And they're kind of linking with some of the psychology pieces that you're very familiar with. The number one thing is having a sense of purpose. So what I mean by having a sense of purpose, and I try and do this myself personally with my patients, you must link their ambition or desire to lose weight with something out of them in the physicality. A child, a job, a spouse, whatever. Make it about the other person out of you as a reason to stay healthy and in good condition. That's number one. Number two is ensure, and this is very important in the psychoanalysis and support of your patient, that you make it clear that we are not attaching the outcome of the procedure to a specific value number in terms of weight.
Okay.
Do you understand me?
Mm-hmm.
In kilograms or in pounds or in whatever measurement.
Yeah.
No. We are attaching the outcomes in terms of what you are achieving with your life. Exercise, sleep, energy, focus, presence,
Your well-being.
emotionality. So what they do then is that they don't have that tendency to either get too disappointed if they don't reach their soul target, or they don't get overconfident when they do and believe they can throw the caution to the wind. So you're literally saying to them, you have to look at yourself as being like an alcoholic. You are part of the Alcoholic Anonymous. You are consistently at risk of becoming addicted. Again, you are never cured. So what you're doing is you're drilling into them early.
So they need to understand that the size can go back.
Oh, 100% from the word, yeah.
Because the thinking is,
I beat this, yeah. It's a complacency kind of.
So the stomach it's a cell. It can.
Yeah. It won't go as big as it ever was prior, but it could still become.
For me to finish a whole plate.
Yes. So what you're now doing is you're going back to this thing you started with, this, why can't you just have a small portion and be satisfied? Why must you get to your limit? Why must you? Are you with me?
Mm-hmm.
And it does require a lot of deep work. And there's a bit of substitution that comes in also, which I didn't say, is you must substitute because food, food has a purpose, right? Food in a lot of people who have eaten enough to be quite large over the years, the food has filled in a gap in their life or their presence. So once you take that away, there's a void, right? You got to fill it. Find something. So that's why you must always do this thing they call substitution. You must transition.
That's where I was going to ask you about addiction. There's one thing I read in that group. A lot of people have picked up an addiction
to something else
after the surgery.
Yeah.
There were a few of them that started using alcohol.
Yeah.
What is the link with letting go of food and the brain looking for
something else?
Yes.
Something else. Yeah.
The addiction, because there was an addiction to food. And the brain is looking for what else are we going to do? You've taken this out.
It is very complex.
How do you help
truly is complex
to replace that addiction?
It's hard. I think I tend to tell them to focus their effort on work and exercise, and of course the people they love. So I look at it that way.
The feel good with that is not the same with the food and alcohol. The brain.
I know. But then, I haven't got I'm just giving you my own tools, and I have some of my patients that add weight. I have, some that don't. So I don't even know. I haven't been able to find nobody's been able to find a good solution. I think that, I believe that, it's probably worth jumping in with the psychology piece
analysis
at this stage, because actually what you really want, what I think we should be achieving, or we should be looking to achieve with these patients, is once we get them to a very comfortable place with themselves, which is self-love. Because ultimately it's self-love.
Right.
You want them to fall in love with themselves again. because a lot of them aren't in love with themselves, I must say. But you want them to fall in love with themselves again. And then have that connection and relationship with themselves that they have created or crafted through their efforts, which is why they have to do the journaling and so on. And then at that point of power, get them to, we haven't done it, but I mean, we'd love to get them to then go into a form of psychotherapy sessioning to really, for somebody to deeply see where the gaps in where they are. Because usually they are. And if they haven't filled them by that point, they're going to go back to something. So you can find that. So it's very complicated. Honestly, it truly is. And
as easy as
oh no.
think.
Oh God, no. No, God, no.
The easy way out.
No. Yeah, but don't forget, I mean, you know, how we choose and what we do is, I agree, it's linked to dopamine, which is what you talk about, the reward centers of our brain, and how we trigger and reward ourselves, you know. But you need to understand that, because actually you can reward yourself with other things to get the same amount, because of course you get this thing called dopamine overdrive. So you can actually exhaust your dopamine receptors by giving hits. You need high and high hits. So you do like a detox. You come away from the dopamine, go crash, and then your receptors fill up again. And then, so the different tools you can use to keep yourself, and then come down, detox, detach, and then go back again. Yeah. So, you know, but then it needs some expert help to guide you.
So, almost last question. How do I take care of my new pouch that I have?
Yeah.
After I've done the surgery, after I have passed the 3 months mark, and I'm all off like a baby. Yeah. I'm off. I'm good. I don't need Dr. Okaro anymore. So what's the best way to take care of my new stomach without stretching it out and not coming back to you again for adjustment?
I think every day you recommit to keeping your priority of your health and wellness. I think it's a daily committing. It's a bit like they do in Alcohol Anonymous. It's a daily prayer. I think it is. It truly is. Yeah.
Mindfulness.
And the other thing that I think we didn't say, which I think is really, 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 really important, is the influence of environment.
And the people you
environment. So environment comprises home, work, friends. Yeah. And then of course events. So you sometimes have to re-engineer your environment.
So I have to lose some friends that are foodies before with me, probably.
Yeah.
That remind, addiction, you stay away from.
Yeah.
You know?
Triggers.
Yes.
So I think, you may have to consider that, I think, but that has to be the part of the conversation. So the house has to be remodeled. And that's why I always want partners to join them on the journey. So I don't like a journey. So, you have this sort of meal.
Triggers, that's still
you
there.
have a meal prepared for mummy, meal prepared for husband, wife, whatever. No. We're all going to go on the journey together. So I encourage a lot of that, because your biggest chance of a relapse is the amount of temptation you have in your environment.
So basically, post-surgery,
it's a lifestyle. Is a complete transformation of life. Complete. And if you take it right to the limit of its impact, and you take it right to the limit of the changes in lifestyle, the changes of understanding of food, the ability to feel younger and look younger. Don't get too attached to people's opinion. Don't get too high on the compliments. It's hard, but try not to. Don't internalize them. Don't, relive your youth. Yeah. It's hard, especially if you've been fat for a little while. You go out and you suddenly, honestly, we see this. Honestly, we can go a little bit into the lighter mode. You see women, particularly women who, as a young girl, who very, very pretty girl, facially really pretty, that came and she had a surgery under me. And then about a year later, or 6 months later, she'd lost a lot of weight. So her beauty really became very obvious to everybody. And I think she started to get a figure. And then in her office, some of the men started to show an interest. So she got really upset. You've been seeing me all these years. Now you never showed interest. Now I'm losing weight. And I said, I'm not gonna date you. I said, well, you didn't really like him. You did. You know, dated him clearly because, of course, what difference does it make now? But just joking. Sorry, I'm just joking.
But it's
you never really liked him anyway.
No,
so
but that is true.
You would have taken up.
Even in men lose weight. Women all of a sudden like, oh, okay.
Yeah. So you're right, and I think the point to this was always
so
about,
she did not expect people to notice her.
Yeah, people started to notice her, and there was one particular. I mean, we have a lot of stories. I have a lot of social stories that are really interesting.
I would love to have one of your patients.
Really interesting.
If they're willing to talk to
tell you about
their journey.
We've had divorces. Yes. We've had marriages.
I've seen the divorces on the page as well.
Yeah, we've had divorces.
There were jealousies and had attention being given to the spouses.
Yeah, we've had stalking. We've had everything go on.
I've seen the divorces.
It's crazy. It's crazy. But it's fun because what it does is
But I think with the divorces also, part of the stories I read was because they lost weight and they changed. Mm-hmm. They started feeling good about themselves.
Yeah.
Their dressing changed. Their energy changed.
Yeah.
And the partners couldn't handle that.
Yeah, well, that's a completely different podcast because I think that is really around the dynamics of relationships and the power pieces in relationships. Because that truly is. And then you begin to then unpick the issues of are you elevating the person with you or are you bringing them down?
How young, how old how old
can I have surgery?
Yes.
Yeah. The youngest we've done for a balloon was like 13 years.
It was a balloon?
13, yeah.
Okay.
Surgery, I think it was about 16 maybe. Mm-hmm. And you could only do a sleeve in a young patient. You're not allowed to do bypass because they're still growing. They need all their absorption, so you're not allowed to do it.
But they also have to be on meds, no?
Yeah, vitamins.
Vitamins.
And then older, I think my oldest patient is like 78. I think, yeah.
Sorry, what?
I know. That's crazy.
Sorry.
78, yeah. I did a sleep.
They have hope.
She did good, yeah. She did really well, actually. But she was diabetic.
78.
Yeah. I know. Interesting, yeah.
Where can we reach you if people want to reach out to you?
Yeah, if they want to get us, we're on Instagram. Two big platforms, obviously loseweight.com or loseweight.metabolic-surgery-clinics.com. Eurocare, which is where I'm based, Eurocare. And then, of course,
Eurocare where?
Victoria Island, sorry. Yeah, Eurocare, Victoria Island, Lagos.
Okay.
And then through Cherise Carib Health.
Okay.
These are the quick channels into us.
Great.
Yeah.
Thank you. I was going to ask you whether you worked out yourself because your guns are out under your scrubs. Yeah. Oh wow! Now you had to flex it.
No. Well, no, of course.
Do you work out yourself?
Oh yeah.
So busy doing surgeries, you don't really.
No, I do work out.
Lift weights or cardio?
No, I do cardio. I do a lot of running and cycling because, of course, you have to remember. We all have to remember that our sort of vessel, our sort of the thing that harbors our brain has to be looked after in order for the brain to function well. And of course, nobody wants to go and get recommendations for surgery from a fat surgeon. Doesn't make sense.
I haven't thought about that.
It doesn't make sense.
You go consult and he's big.
And he's fat. He's like, he's going to take a bit of your medicine. So I'm just kidding, but yeah.
It's actually literally like going to, what's it called, an instructor in the gym as a personal trainer.
Yeah, you find that they're skinny as a rake. You were like, can you really teach me how to do these bench lifts? So no. I mean, I exercise, and I've exercised as a kid because it's important to keep the body in good shape because it helps, and it helps my memory. When I did go through periods when I wasn't exercising, my memory was really quite poor.
Okay.
And I have a family history of diabetes. I have a family history of dementia. I have a family history of hypertension. So, I have, my genetics clearly shows that if I'm not careful, then I'm going to get into trouble.
Gene is there, not trying to trigger it.
Yeah, correct. Epigenetics. I'm trying to change my environment. So that's why I'm very conscious, And it gives me energy. I stand on my feet sometimes 3 hours operating. If I'm not in good condition, how am I going to work well?
Thank you.
Thank you
so much. I hope it was a bit different from what we were doing before, no?
Very much.
How do you like the vibe?
Extremely revealing.
How so revealing? You still have to give me the checklist, you know that, right?
Extremely revealing. No, I mean, this has been interesting. I've actually never done a podcast before.
Oh, okay.
Never. I've never done a podcast. So I'm obviously a little bit nervous, but it was a little bit anxious.
Was that good?
Oh, you were good. I mean, you're very good.
No, did I make it comfortable for you though?
You did. I think that when I was, when we spoke about having this, I was a bit.
What is it all about?
But actually, no, I enjoyed it. I've enjoyed it, and of course, most importantly, I hope that it comes out. I think in a light, that helps people to.
That's what I was asking. Questions.
Yeah, exactly. To understand, it is a serious business.
That's it.
And there are dangers.
It's not a quick fix.
And they are dangers, and I think there are little trip-up points throughout the whole journey. And there's a lot of interesting things happening in the region, which is the African area around wellness. Nigeria has traditionally had struggles with quality of healthcare, not just in terms of cutting edge, but even some of the routine stuff, and that's partly because we're a relatively poor country, and we've also got poor standards. We've got poor oversight.
There's a regulation
issues. So there's so many. But on the other flip side, there's some very good pockets of, I think, excellent work going on around. Lagos tends to become the looking fast-growing hub for tourism. And I have patients coming from Canada. I have patients coming to me from UK. I have patients coming to me from Sierra Leone, Senegal.
You're Black? Or is it because they're
not. Most of them are Nigerian. The ones that come, the ones that come from Canada, UK are Nigerian.
Okay.
Yeah. Now the ones coming from the West African coast, Ghana, of course, Sierra Leone.
Do you do surgeries in Ghana as well, or they come here?
I do a little bit of both. I do balloons in Ghana. I'm starting surgeries in Ghana. I think this year.
Do you need an E in Ghana? How? What's my E ammo? Anytime.
Hired. I'd love to work.
Did you hear that? The voice.
Indeed.
And I'm a psych.
True. Yeah, that's that. We need to
pre-psych.
We will need to
behavioral, the CBTs.
Yeah. So clearly, I mean, I think we there's a lot of synergy between you and I. We can work on this. But so with the point that they're coming because there's nobody in those countries doing it.
Yeah.
And that's why they're coming to Nigeria. But I think we want to, so that's one. So
do you think there's a bit more of also a trust issue there, trusting you more, being one of us?
Yeah.
And doing it with us, knowing our bodies better? Are our bodies different or different?
No.
Or inside the same?
No, all the same. No, completely the same.
Do we heal the same too?
All the same. Maybe a little bit better here because we don't do... Smoking is a big, smoking reduces the ability to heal, so we do less, there's less smoking here than there is obviously in Europe. No, you're right. I mean, I think that the trust piece is there. There's a cost piece. It's cheaper. Obviously, Canada is cheaper here. In England, it's cheaper here. Mm-hmm. So there is a price. So the whole tourism business. But the other thing that is happening is that I think that, and you highlighted this, but we did talk a little bit about this, is the demand for this type of work in the region. So in Nigeria and around the African area is going up. And it is projected to go up.
We're becoming more aware.
Correct. The awareness, availability, maybe people don't need to travel overseas to get it done.
Comfort of their own home.
So there is a responsibility to help hospitals, individuals to be able to offer safe, quality practice.
What about the fear of it's Africa? How safe is it? Because there are no regulations.
Yes, that's why you have to be very discerning. You have to do your inquiries. You have to really research your surgeon and their team. Mm-hmm. And internet carries most of that information, to an extent. It's usually quite obvious who's, visible or who's done what. So that could be. But then, as we said earlier, just talk to your surgeon. Ask them how many cases, any difficulties, you'll know. And then, of course, you have the most important sensor, which is the inner comfort. Yeah. When you're comfortable in somebody's presence, it's usually a good sign as against not comfortable.
Right. What's the budget like right now? Like for the sleeve, like I'm not asking the exact. Like what's the budget?
I think it's with the rates fluctuate a little bit, but you're looking at about 10 to 11 to 12 million.
It's gone up.
Yeah. Keeps going. Yeah,
because I remember the last person
it's
I
about 8, maybe 9.
It was. I think it was like 6, 7.
Yeah, probably. Yeah, but I mean, it tends to always sit at around 7.5 US on average. It's always been that since the beginning. 6, 7.
So in Naira,
you do the equivalent.
So in Naira now, your average. Do you know? I know you have a team that does all the finances. In Naira now, locally, like what is the budget? Like to be okay, like, okay, I've saved up so amount, let me go and do inquiry. Like, how much should I save up?
So, because the market is, the offerings are split. Mm-hmm. The offerings are split. Back on what we said earlier.
What's that?
Back on what we said, the offerings are split. So, if you're looking to have surgery in the country, and you're not particularly concerned who does your surgery and where you do your surgery, yes, then you could probably get it for about $3 to $7 million.
No,
million Naira.
Sorry, what?
3 million, 7 million, 6 million Naira. If you're not interested in who's doing your surgery.
Oh, okay.
So this is now the spread of offerings.
Right.
I'm talking about Lagos.
Right. So if you're looking at...
So if you're going to a more reputable center with surgeons who have been well trained, you'll be spending about 9 to 12 million. And they're about 2 or 3 in Abuja, between Abuja and here. Okay. But if you're going to somebody who's just, happy to offer you surgery, you may get it much cheaper.
Wow.
This is Mary with the Voice podcast, healing souls one story at a time.